So hello, my name's Sarah Partridge. I am a pharmacist associate that works for Nottinghamshire Reliance Training Hub. And we knew that just before Christmas, the asthma guidance changed. We thought it was important that we gave you an update. So I was delighted when Natasha agreed to do this training. So I'd love to introduce Natasha Hudson. She is a specialist clinical pharmacist who works both in severe asthma and in the general respiratory wards and works at the Nottingham University Hospital's NHS Trust. So I'm delighted to hand over to her.
Perfect. Yep. So I'll make a slow start and hopefully we'll get a few more people join as we go along. I've been given a few ideas of what you guys might want covered, but at the end of each section, I'll sort of pause for any questions. So please drop them in the chat when you're thinking about them, or pop yourself off mute once I ask for any questions, because hopefully this is kind of your session, not just what I want to talk about. It was mainly looking at the NICE and BTS guidelines, but I do have some input into the Nottinghamshire Guidelines. We've got another meeting tomorrow, so I can show you what we've got what we got net so far, and then I can say what's coming going forward. So these are just my disclosures. So in terms of outcomes, we'll obviously go through the new guidelines and then understand why we've moved away from SABA to using these combination inhalers. A bit more detail on what we mean by MART and AIR and what's that going to look like actually on the NOTS formulary, and how do we navigate these conversations with patients. I'll touch briefly on the asthma diagnosis recommendations as well, as these have changed, and as I said, some Q&A sessions as well. So the first bit is on the new diagnosis pathway. So these diagrams and sort of algorithms are all from NICE, and make it a bit simpler than all the wording that is available on the NICE guideline. The main thing to point out is that you still always start with a structured clinical history for a patient. You don't start looking at this order of tests until you've actually got a presumptive history of asthma. So you've got a patient that you've got, key notable symptoms such as wheeze, noisy breathing, cough, breathlessness, someone that you think has got asthma. We're not just putting every patient through a blood eosinophil or FeNO. It's for those patients that you want to confirm with an objective test that those signs and symptoms match the asthma diagnosis. So for those patients, the first line now is blood eosinophils or FeNO. And they've done that because we know that Spiro is a considerably hard issue to try and get at the moment in primary care and in secondary care. So they've tried to go for something that most practices and hospitals will be able to access. Now I know FeNO is variable across the region, but hopefully because it's now in the guidelines a lot more, it can try and push the ICB to get a bit more access to. But if not, we can do blood eosinophils. And because there's such variable laboratory markers across the country, they haven't set a specified level. They've just said blood eosinophils over your normal laboratory marker. So it's most people that's 0.3 or 0.4. I think some have a very high of 0.5. And then if you have FeNO, it's a FeNO of over 50. That's quite a high FeNO. We have some asthma patients that would have a lower FeNO than that. But it does mean if you get that diagnosis, you could be quite confident in that diagnosis. So we're not going to be, I think there was some worry that we're suddenly going to be diagnosing lots more asthma patients and over-diagnosing it. But they've kind of tried to set those levels a bit high. So we're going to be getting those patients that have definitely got asthma. And also you've already ruled them in because of their actual clinical history. And then if those are negative, we then move on to the spirometry. So that is still important to do. However, we know that's often delayed or not available at the moment. So the next option is your peak flow variability testing. So it's a 2-week peak flow diary, and you want to see if there's more than 20% variability. Now that can be quite complicated to actually calculate. So there is an Asthma and Lung UK peak flow variability calculator, and I'd recommend that as a good option, just to help test that you've got that calculation correctly. With peak flow, it's always important to remember that it's only as good as how the patient uses that peak flow, so their technique. We've all seen patients that do a peak flow of, and they don't put any effort in. So it's important that we counsel patients on that technique as well. And we consider that when we're analysing the results as well. If those is still negative, then we'll be looking at a bronchial challenge test. And we do mannitol testing for patients, even that have made it to our severe asthma service, that just haven't got that confirmed objective test from any of those 3 options so far. We will do a mannitol test and see if we can confirm that asthma diagnosis. So that is the new diagnosis pathway. Just wanted to take a quick second and just see if there's any questions about that.
There's nothing in the chat.
I think in the chat, anyone want to come off mute? Is it probably a bit too early for people to feel confident yet? No worries, that's fine. If there is anything, I can come back to it later. But I'll move on to some conscious. Oh yeah.
Questions just fed. What's a bronchial challenge?
So it's we use something basically to try and get the airways to respond, to show that they're reversible. So we use something called like mannitol. Is often the most common one. We're basically trying to induce that bronchoconstriction, so we can actually then show it's reversible to sort of salbutamol and things as well. Sometimes we just can't get that data without sort of inducing that bronchoconstriction for patients. So it wouldn't be suitable for everyone, and it's obviously done in a hospital setting. That's why it's one of the sort of further down the line as a test.
The questions are appearing now. How many tests do you need to diagnose? 2, they put in question mark.
So no, you can start that. So this is a flow diagram. So if you've got the high eosinophils or high pheno and you had your clinical history that was suggestive of asthma, that's it. You don't have to keep going down the pathway. Now we would say from a severe asthma centre point of view, we would still be good to get spirometry, because later down the line that is useful for us to have. But you could just stop at that first box. So it's not something you have to keep going and get through in all of them. It's just a case of if that first one doesn't, you don't have any positive tests, you then move on to the next one.
And then Maria has said, so to clarify, if bloods are negative, then pheno, if negative, then spirometry, if negative, then PEF, and if negative, finally bronchial challenge.
Yeah. Yes. So it's just working through that order of tests. Yes.
And Elizabeth says this is for over 16s, yet the 5 to 16-year-olds were covered in a different talk that was last week. So hopefully we'll be putting the recording on for that.
Yes, and this is just for over 16s, yeah.
And Susan has asked, can I ask how we identify other phenotypes if all other tests are negative?
So your blood eosinophils and pheno are more looking at your type 2 information. So especially your eosinophilic patients. We would often, those sort of patients, we probably will see them in a severe asthma centre. Nowadays, neutrophilic asthma is probably questioned because actually a lot of those patients may just be on steroids or have had something that's dampening down their eosinophilic trends. The other option to look at is IgE to look at allergic asthma, and you can do look at the triggers and look at what their reactions are to sort of dust mites and things like that. But we wouldn't necessarily expect you to be doing all those tests in primary care.
Brilliant. Thanks for that, Natasha.
That's all right.
There just has been a request for you to very briefly just cover this slide because of the late joiners.
Okay.
And then we can maybe move on.
Yeah, so very briefly, this is the new diagnosis algorithm. It's all on NICE, and this picture is taken from NICE. The main point is the order of tests at the top. So you would start with blood eosinophils or pheno. If these are negative, then you move on to spiro, etc., etc. So you're just working down in order. You don't have to do all of them. It just gives you the options in terms of which to go with first. And you'll see at the bottom what the how to interpret those test results. And that's probably a very quick overview. I'll move on just because I'm conscious there's probably a lot to go through in terms of the pharmacological side of things. Again, this algorithm is from NICE and BTS. I think it It's relatively simple, but it's quite a lot of information all in one. So I'll break it down into specific sections. What it is important to know is the main part, there's no SABA on the new pathway on the right. So we're getting rid of our salbutamol. They really want to have early step up and review. So whenever we make a change, patients should be seen within 8 to 12 weeks, and that's the new recommendation. They want patients to be getting through this pathway quicker. They want them to get referrals to the severe asthma service quicker. And that's all because we know that patients do better if they're put on a biologic earlier, before they've had lots of damage from their steroids. So we want to try and make sure the right patients are seen by us quicker, rather than sort of waiting and keep trying different doses like we have done previously. If it's not working, let's try something else. There is also sort of phenos mentioned now in the new guidelines as well. So there's another point there which we'll get to. And it also just highlights, before stepping up, the key points to look at. We always want to check we've got the right diagnosis, check adherence, check technique, think about psychosocial factors, environmental factors, just think about that whole holistic view of that patient. So we'll go into a bit more detail. So on the new pathway for a patient that's newly diagnosed in asthma, and we're going to talk about patients over 12, because that is what our adult Nottingham guideline will cover for patients over 12 and over. So what is AIR? So AIR is an anti-inflammatory reliever. Okay, so it's an ICS LABA, so inhaled corticosteroid and formoterol, and it has to be formoterol, which is used in response to symptoms without regular maintenance therapy. So it's just an as needed. There's only 3 licensed products at the moment for this. Obviously more may come. What is important is patients just have this inhaler. They don't have any SABA at all. The licensed ones are listed there. Potentially, there's still some discussions about which ones we're going to go for on the Nottingham guideline. The likelihood is we're probably going to stick with your Symbicort and Fodby mix, because we've already got quite used to those. There's also, I think WOC AIR has now also got a license, but that's not one that's on our formulary at the moment. So we may try and avoid adding too many more inhalers to the mix, because I know it gets confusing as it is. However, we'll also like to recommend some off-label options, because obviously, as you can see, the only ones that are licensed at the moment are dry powder inhalers. So obviously they are recommended first line, but we need to offer an MDI option as well. So we're probably going to mention sort of Lufabec or Bibecvo as an option. So what is AIR versus MART? When do you start AIR? It's only for patients that are symptomatic once or less a month. So it's a very, very small proportion of patients. We won't see them in hospital. They're going to be patients that you're going to see probably more in the community. And it's going to be a very small proportion of patients. It might be those that, if they go see, I don't know, a cat or a horse, they might have a bit of symptoms, or very rare sort of exercise induced. It's not going to be many patients that are going to be suitable for AIR. If they're having symptoms twice or more a month, that's it. We start them on MART. So as you can see, you can either go from the newly diagnosed to straight to AIR, or if they're highly symptomatic, so if they're having 2 or more symptoms a month, then we put them onto low dose MART. So MART, I'm hoping most of us will already be familiar with. So you've got your ICS formoterol, where you have your daily maintenance, and you have your reliever as the same inhaler. Again, we don't need any salbutamol. I regularly see patients coming in on a MART inhaler as well as salbutamol, and they're taking both because they're not quite sure. So it's really important, if we're putting patients on MART, that inhaler is still their reliever. And what we mean by low dose MART and moderate dose MART depends on the dose we give. So for Lufabec, it'll be one puff twice a day for low dose, and then 2 puffs twice a day for moderate MART, and same for sort of Symbicort 206 as well. So it's all just dependent on the dosage of it, and we'll try and give some recommendations in the Nottinghamshire Guidelines, so with a nice clear table of what dosing is which, to make it nice and simple. So just Reminder again, saying stop the SABA. It has to be inhalers that contain formoterol, and that's the same for your air. The reason for that is because formoterol is a long-acting beta agonist, but it also starts acting quicker than the other long-acting beta agonists like vilanterol and things that might be in other inhalers. So this means it will work as a reliever as well. It's going to help open up those airways like your salbutamol would have done. I also just wanted to highlight on here the licensing is important in terms on what strength of inhaler we're given. I regularly see patients that have been given Symbicort 412 as MART or Foster or Lethobet 206 as MART. It's not licensed at that point, and that would be a very high dose. So just making sure we're actually giving the appropriate strength inhaler as MART. Okay, so we've gone either from air to low dose MART to moderate dose MART, or just straight up through the MART. And between each step, we've given 8 to 12 weeks, and potentially they're still uncontrolled. What do we do now? And this is where there's a new section again in the guideline, and that is to check pheno if it's available, and a bloody eosinophil count. And again, at this point, we're looking for sort of signs of type 2 inflammation, because if there is, you're potentially going to be better, have a better response to a biologic, and that's where they say to refer. Realistically, if everyone that has that is referred, we're probably not going to be able to see everyone very quickly, considering we've already got quite a high wait list within the severe asthma centre. At the moment, we are potentially going to say to actually look at advice and guidance for these patients first. So if you've got a high pheno, if you've got a high blood eosinophil count and you're thinking it's type 2 inflammation, we'll do advice and guidance first. Then the consultants can have a look and see if it's appropriate to start them on high dose inhaled corticosteroids, and whether we need a referral, whether we could just give some other advice as well. What we don't want is just everyone being stepped up to high dose inhaled steroids. There's information that's from many, many years ago that actually the response in patients being stepped up from moderate to high dose is actually very minimal. They've already got most sort of symptomatic response by the point they've got to moderate dose. They're just getting more steroid and then more side effects. So it's not appropriate for every patient. So we need to make sure we're only doing it for those appropriate patients. If neither of the pheno or blood eosinophil count is raised, you're on the bottom side of this diagram, we've got the options of montelukast or a LAMA. So the NICE guidance doesn't really recommend one or the other. We were probably hoping to try and put some information into the Nottingham Guidelines, give you a bit more detail, because it's a bit, we don't just want to be giving everyone both of them, because the likelihood is they're not going to respond to them all. It'll be more for your allergic patients will probably need to consider montelukast. They're more likely to respond. However, we do need to be consider the neuropsychiatric side effects that are quite common with montelukast. So any patients that have got any sort of mental health history, we often just avoid it because it can impact them quite significantly. So definitely for those sort of more allergic patients. And also, again, reviewing it after 8 to 12 weeks. If it's made no difference, stop it. We see many, many patients on montelukast that have been on it for years, made no difference, but they're still taking it. If they have no real level of sort of inflammation and got fixed obstruction, they're quite breathless, those are the patients that are probably going to do better on your LAMAs instead. So I'd probably recommend trying this breather Respiratory or another LAMA at that point. What is the difficult point here is you're now adding in another inhaler. So you have to then think about what's appropriate for your patient. Do you want to add in something like a sprayverespamat or dry powder in tiotropium, or do you want to add in? Do you want to stop their MART inhaler and add them onto a triple therapy inhaler? And that's going to be a bit of individualized for those patients. Some patients will be better off just keeping on their MART that they're happy with, they know how to use, and then to add in a separate inhaler. But others, it's going to be easier for them to just be on one inhaler they only have to know how to use. But then you do have to introduce a SABA. We are hoping to put in a bit more information about triple therapy because it is a bit more difficult now MART is involved. That's just that point. So that's all very well for new patients, but obviously we've got an awful lot of patients already on treatment in the community. So what do we do for those patients? So if they're on sort of salbutamol or terbutaline only, first thing we would want you to do is just to check it if it's definitely asthma, because if they're only needing salbutamol and they are not, not needing any prednisolone or anything like, or not going into hospital, I'd wonder if it's definitely asthma. Is it something else? And it's a good opportunity to review the diagnosis at that point. If it is asthma and we're happy and they are well controlled, then we would switch them over to air therapy. However, if they're not well controlled, we would put them onto low dose MART. And then for patients on sort of the ICS lab or ICS at the moment, you would just switch them to the appropriate low dose or moderate dose MART. But it's a really good opportunity to review all those supplementary treatments as well. So your Montelukast, your LAMAs, anything else that has been added on. Really good opportunity to see, did it actually make any difference? Do we need to continue those for the patients? And again, a really good opportunity to see, are they controlled? And what the patient's view of whether they're controlled and what our view is probably going to be different. So obviously that's quite a lot for us to take in, let alone for the patients. So it's potentially quite a few changes for them. So it's really important to us to consider how we can navigate that change with patients. As I pointed out, it's really important to understand what the patient's understanding of their asthma control is. So many of them think that it's normal for them to wake up with their asthma or to just have a steroid, when it gets a bit cold. And for us to point out that that isn't good control, and actually we might need to change things because they aren't well controlled. We need to understand what MART and AIR is to be able to explain to patients why they're needed. And I'll have a little bit more later on the presentation to go through that as well. Making sure the patients are involved, so offering them options. So we're not just going to say this is the only inhaler that you can have. We're giving them the options. Some patients who are well controlled, we don't need to switch. If they're already on a fixed regime and it's working well for them, then that's fine. But for those that do need to switch, often different options available. Highlighting there's benefits of one inhaler, one technique. Some patients love the fact they haven't got to carry multiple different things. It's a good opportunity to check their technique and update their action plan as well. I know that's a big section, so I just want to take a breath and just see any questions about the new guidelines and AIR and MART and everything.
So no specific questions about AIR and MART, but we do have a question about Pheno. We do not have a Pheno machine. Where do we refer for that?
So in a community, you can get it in the hub or not, but the options in the guidelines are not, you don't have to have had a Pheno. So if you haven't got Pheno at that point, you can just do eosinophils at this section. It's only Pheno if available. So if not, you would just do eosinophil count at that point. If you were going to be referring to us, we would do a Pheno when they come to us in the Severe Asthma Centre. So they've done the guidelines knowing that not everywhere has access to that at the moment. You might be able to get it on spirometry in the community as well, but I know it's a bit sparse.
So Claire's asked, what about symptoms only around exercise? If it's 1-2 times a week or more, would you put them on MART? Some state they have no concerns at all without exercise.
So on the new guideline, it would be on low dose MART because it's over. That would be if it's 1 or 2 a week, then it's potentially 4-8 times a month. So actually we might be having some tissue remodeling at that point if they're having symptoms that often. So hopefully just a low dose MART would help control that. Again, it's quite a big change.
Any other questions? Feel free to unmute as well. We'll happily have someone else speak.
Yeah, someone else's voice is nice.
Other than that, if you're taking it all in, if you have any questions as we go, do feel free to
and I can go back at the end. That's absolutely fine.
But it's really good to have an opportunity to like go, oh, actually, I don't understand. Oh,
Yes.
Elizabeth goes, will there be any clinical scenarios for us to prescribe salbutamol?
The so the only scenario you would be prescribing this salbutamol in the new guideline is patients that end up either on a triple inhaler, so you got your Trimbo, and so they can't mark that and would need a salbutamol, or patients that end up on high dose ICS, as seen by a specialist, and then they also can't mark that, so they'd be on a salbutamol. But no new patients on the sort of beginning part of that journey should need a salbutamol anymore.
So this has opened a whole chain of questions.
Okay.
What if patients aren't happy with the changes and insist on having a SABA?
So for those, I mean, those existing, if they're existing patients, if they are well controlled, then we don't have to switch them anyway. There's always those patients that don't want to switch. These are guidelines at the end of the day. It's going to come down to us explaining the reasons why, and why it's important and why they've changed. If they definitely don't want to, we can only treat them as much as we can. So if we have to keep them on a fixed dose and a salbutamol, because that's what they're going to take, then that potentially is the best option for them. But it's something that we'll probably have to review at each clinic appointment to check whether they would be happy to switch. We know our asthmatic patients will do sort of what they want sometimes. So I think it's just a case of them understanding why and working with them. But these are guidelines. They're not going to fit every single level of patient. This is just what the best evidence is now.
Sarah's asked, have you found much challenge from patients about removing SABAs?
Yeah, and I think it's harder for those, especially sometimes that we see, or some of our really severe asthmatics that potentially, have been in and out of hospital for a very long time, have always been told from the start that is that life-saving medication. And it's very difficult then to take that away. And sometimes we can do it, and sometimes we can't. And sometimes we do just have to do what's best for them, and we work with them. And sometimes it's not the first time you see them, maybe it's the second time you might. And then sometimes we have to go basics of asthma. What does the steroid do? What does the salbutamol do? And explain it in sort of a bit more sort of in the pathophysiology of things, which I'll explain a little bit later, and trying to get it that way. I think we'll struggle with some of our older patients to take it off of them. But what I think is really important for all those new diagnoses, that we aren't giving it to those new patients as well.
Thank you. It's a very pragmatic way.
Yeah.
Rachel has a really interesting question. Do we issue a SABA for patients on MART if they have an asthma attack and they don't respond to their MART? It was recommended in the session last week for under 16s that we do, but no more than 2 in a year. So is there... Yeah.
No. You can use your MART, obviously, as for an asthma attack. If they're having to use considerable amount of their MART, we need to be taking them, they need to be going to hospital. We know that if we give them a salbutamol, they're going to take that as well. And the data from all the MART trials all showed that patients could use this in an asthma attack. So I think it's, otherwise we end up with patients on both, and it causes confusion. So within adults, we won't be recommending that they need that in terms of an asthma attack. You would just use your MART inhaler. And if you're needing to use it more often, then it needs to be coming to hospital.
Claire, could you clarify your question? And Ruth, Natasha's going to clarify the reasons for the changes a bit in some of the later slides. You've answered the SABA. There's some comments about SABA in pediatrics and whether it's the same.
I'm not sure whether they will recommend something different in pediatrics, but I know within adults, for any of us asthmatics, we aren't recommending they have a salbutamol on side. We just say you have your MART inhaler.
And then what about asthma COPD overlap?
I suppose you've got, so if you're treating, depends what condition is the most predominant, what's causing the exacerbations, I would say. you can often see which one is potentially, you think, more likely to cause it. If they're on a MART, they can still use their inhaler PRN. I think we have to be a bit pragmatic about what that specific patient is going to do. Are they really clued up? And sometimes you can tell whether they're going to be having a bit of both, or are they going to understand when to use which I'm not sure they will be able to tell which exacerbation it is. So I would probably just say you stick to one or the other.
Is there an alternative for those patients that are sensitive to formoterol?
Unfortunately not. No. And we have those issues. So those patients, I say these are guidelines, it's not going to fit everyone. We've got patients on things like Relvar, which obviously is a different LABA, and obviously you can't MART it. And that's useful for those patients that just want to take something once a day as well. So not every patient is going to fit nicely into those guidelines. You still will have to use our clinical judgment if they don't fit nicely into it. So we've got patients that have issues, lots of different steroids as well. There may not be one that's licensed for MART. So those ones would have to fall outside the guidelines and potentially try something else.
Thank you. I think that's most of the questions asked.
Yeah.
If there need any that need clarified, put in chat, and we'll come back to it in the next section.
Perfect. Okay, so just some sort of points to think about when we're ever seeing our sort of asthma patients. Now, I'm hoping that majority of you know about the green agenda already. I feel like it's very prominent at the moment. There's obviously a push to use dry powders because they don't have the repellent in them like the MDIs, which does have that global warming potential. I always think it's important it's not about switching everyone, it's about using it as an opportunity to see patients are on the right inhaler for their technique. I just want to note that there will potentially be some next generation propellants expected, hopefully, this year. So some MDIs might actually be equivalent in terms of carbon dioxide to dry powders in the near future. So it's just about making more the patients on the right device for them. And as well as costs and the green agenda as well. Also, it's always data. It's a bit of an old study, but we can't expect the patients to do the right technique if, as healthcare professionals, we don't know how to use it. And there's always lots of studies of how we never quite get it right ourselves. So just wanted to take this opportunity, if you don't know how to use inhalers, to point you to the Asthma and UK website and Rightbreeze, both free and easy to use for healthcare professionals and patients alike. And I do direct my patients to them, especially we give them a new inhaler, or I might use their videos as part of our counselling for them. Just try and highlight sort of especially how slow and steady that MDI is. And also we use the in-check devices quite a lot in secondary care. I know some community teams do have them, but they are very useful to help in check if a patient can use the device themselves as well. Just also wanted to touch on adherence, as that is a bit of my bread and butter in my day-to-day job, and it is now mentioned particularly in the NICE guidelines. So check adherence using prescription records and inhaler technique at every asthma-related healthcare review, and that's because we know that poor outcomes in asthma are linked to non-adherence to medicines and SABA overuse as well. So it's really important to be checking that patients are picking up their medication. When a patient is referred to our severe asthma service, every new patient gets one of these proformas done by myself or one of my new technicians, and we look and see what medication they're on, and we'll see whether they're having their inhalers issued on their GP systems, and what other medication they're on. We'll also look at how many times they're being issued salbutamol and steroids as well. And we calculate something called a medicines possession ratio. So it's basically how many inhalers they've been issued or picked up from their pharmacy compared to how many we'd expect over a year. Now, obviously, this doesn't mean they necessarily take them at home, but it's a best estimate that we can give as to how likely they are. We're not looking for 100% because no one's perfect, and by about 75%, the patient should be getting a symptomatic benefit of them. So we have a look and see, are they adherent or not? We'll also look at how many sort of steroid courses they're having as well. And when we use this to sort of see which patients need to be seen earlier, and which ones we're a bit more worried about. But those key points that potentially when you are in an asthma review, checking to see how many issues they've had might give you a good idea if they're picking up their inhalers or not, and might be a good point to talk about. So I also wanted to highlight that we're going to be moving away from the Nottinghamshire Asthma Action Plan and going to be moving to the asthma and non-UK ones. So there's separate ones for sort of fixed dose, MART and AIR. So it's a bit more flexible for the different regimes that patients will have. So that should also be launching when we launch the new guidelines as well. It should mean it keeps up to date a bit better than our current one. Oh, I'd just like to put on here the some of the key definitions of sort of what uncontrolled asthma is, because I think sometimes we and patients get used to their normal, what normal is for them, and sort of forget that actually this isn't controlled asthma. They get used to having a bit of shortness of breath or wheeze, and they just think that's what being an asthmatic patient is. So it's just reminding ourselves again that it's uncontrolled if it's having an impact on their lifestyle. It's restricting their normal activities. If they have an exacerbation, that means it's uncontrolled. Any exacerbation, we need to review and actually make a change. And whether that's a case of they're not picking up their inhalers or they've got wrong technique, or whether it means we step them up in terms of treatment, but something needs to be done because they're uncontrolled at that point. And if they're needing a reliever inhaler 3 or more days a week, or being woken up 1 or more nights, again, that is uncontrolled. And we need to change the culture generally in the community, just nationwide, that is bad asthma, and we shouldn't accept that, and to help patients to notice that is uncontrolled, and to want to change things. So as part of the new guidelines, we're going to have a bit more on referral criteria and how to do so, because I know the recent ones aren't very clear for you guys. So we're going to try and make it as easy as possible for you, because then it also helps us as well. So in terms of the new guidelines, when you would refer, you would either be on high dose ICS-LABA if you had some advice and guidance to do so, or you'd be on the medium ICS-LABA plus or minus Montelukast or LAMA, and you've had the need for corticosteroids in the previous 12 months, so basically they're uncontrolled. High use of SABA, so that's if they're on high dose ICS-LABA or a fixed regime. Any patient on maintenance oral corticosteroids should be referred if they're on it for asthma. There's no need nowadays for patients to be on maintenance steroid courses for asthma when we've got new biologics and things to treat it. It's just causing a lot of damage for that patient, so we want to see them as soon as possible and get them off those steroids. And also, if those patients you can't confirm a diagnosis, thinking back to the first section on diagnosis, if you haven't managed to get a diagnosis, you might need the bronchial challenge test, which is mannitol. So if you need that, that would need a referral. Particularly those high-risk patients as well, that are having lots of emissions. If you're not sure what we know about them, we probably want to have a look over and just check that they're all optimised as well. Before you do refer, just having that moment just to check, okay, we've definitely got that asthma diagnosis, we've confirmed it with that objective test, we've checked their adherence, so we've optimised that, we've optimised their inhaler technique, we've got that phenol eosinophils and Spiro if we can. We've looked at why and when they're taking the corticosteroids. They're getting the benefit from them. They're taking them when it's appropriate. They're not just taking them because they're anxious or for other reasons. And we've tried to optimise them as much as possible. How to refer, so it's on the subspecialty referral assessment service. And in terms of what you should include, just some bits from the consultants they asked me to say. So making sure as much as clear history of the patient as possible. A documentation of the number of steroid courses for asthma. So sometimes we get them and it says 15 and actually it's for rheumatology things rather than asthma. But it's really useful if that says 15 courses for asthma. We're going to want to see that patient really early compared to someone that's maybe just got 3, just because we're really concerned about that patient. So it just helps us to prioritise when we have got that waiting list to see those really high risk patients first. Letting us know what other sort of asthma medication you might have trialled, and what their sort of last asthma review and technique check was. Again, checking their adherence. We've ensured that's appropriate. And one of the consultants said it's really useful if you've got spirometry in primary care, if you can attach it to the referral or advice and guidance, just because that helps them to then give you the best information going forward as well. So I'm going to pause again and just check if there's any more questions before sort of the last bit.
So Alexandra's asked, can nurses refer to the severe asthma team, or does it need to be a GP?
I got asked this the other day, and I don't think it makes a difference as long as you have access to that, because I know it's often the asthma nurses that see them in primary care, so you probably know more about the history of the patient than some of the GPs. So if you have access to it, the GPs are happy for you to do so, that's fine. As long as we've got that information, that's okay.
So Charlotte's just asked, what's MPR? So you might just need to go back and refresh on there.
Go back. So it's called medicine's possession ratio. So it basically means that we've how many inhalers they've picked up over the past 12 months compared to how many you'd expect. So really simply, if you look at a 120 dose inhaler like your Foster or your Lufabec, if you're using that 2 puffs twice a day, so 4 puffs in total, that'll last about a month. So you're expecting 12 inhalers roughly in a year. So if they're already picking up 5, you can pretty much guarantee they're not very adherent. If they're picking up sort of 10, fine, that works out as about 83%. So we'd be happy with that. So I'm not expecting you to be, this isn't necessarily your day job to be doing all this adherence checking, but a rough idea of having a look when you are seeing those patients, if they are regularly picking them up every month or so, or are they just, missing it, they're only picking it up in the winter period. Just those little key things might just help you optimize a patient rather than stepping them up. It might be something that we can just tweak their adherence there for them.
So Susie's asked a question about where to get the booklet. It's on the Asthma and Lung website.
Yes. I think we'll probably put a link on the formula. I think once we publish it all, should make it all easier for you as well.
But it might be worth centrally people contacting Ardens. They use Ardens Care Plan. If there is a big change, Ardens can be changed by contacting them potentially. So that can happen. So it might just need it highlighting to Ardens.
Okay, that's fine. I'll just wanted to finish on sort of, I think it's a lot of information, and I think it's just a point to go back and say, why are we changing this? Why has there been a big new update? And if we understand it, we can then explain to the patients better as well. So why are we moving away from that SABA? Why has it become this something that we're not giving anymore? So I think it's important to just go back to the real basic pathophysiology of asthma. So you see on the screen, you've got your normal airway and your asthmatic airway. So you can see in the asthmatic airway that yes, during your airway muscles may contract more, particularly during an asthma attack for patients, and that's where your salbutamol works really well. It relaxes those muscles in the airways quickly and for a couple of hours. So that's where that is all the salbutamol does. So it's just going to open those airways up for a short period of time. It's not going to do anything else for the asthma. Because what else happens in asthma? You're going to have your excessive mucus production. You might have those epithelial, subepithelial cells are going to be swollen. They're going to become inflamed, leaving even less space inside just in a normal airway, not even during an asthma attack. And though the steroid inhalers can help reduce that inflammation, reduce that mucus production. So open up the airways all the time, not just during an asthma attack. And if we leave that ongoing information to go unchecked, so if we're not giving them any steroid regularly, the airways, ongoing inflammation can lead to development of scar tissue and what we name as tissue remodeling. And that means there's thickened airway walls and increased smooth muscle. So the longer patients are untreated without any steroid, the more damage those airways become, and we can't then rechange that tissue remodeling. Those airways are always going to be a bit smaller, even if we give them more salbutamol. So what we need to get across to our patients is, yes, the ICS Motorol will open up the airways in that acute attack, same as salbutamol. So it's already doing that one job that patient's really sort of worried about in the acute phase. But it's also doing all the other jobs that asthma happens when they don't notice, when they're feeling well. There's still that ongoing inflammation happening. And if we leave it unchecked, it's potentially going to make them feel worse over a longer period of time. So we need to help reduce that inflammation down with those steroids and prevent the remodeling going forward. And that's why we want them to have that steroid when they're well as their maintenance, but also when they're poorly as well. And that's just sort of overlinks those key points. Also, SABA overuse is still a huge problem linked with mortality. And we already know that a lot of our patients do a kind of MART regime anyway. We know they don't always take their regular inhalers every time. We know they use it when they're poorly, and then they don't use it as much when they're well. So patients are already kind of doing this. We're actually just informing them how to do it appropriately. And it's also easier for adherence to have, for patients to just have one inhaler, one kind of technique, because so many patients have an ICS LABA, dry powder inhaler, and then a salbutamol MDI. Two different inhalers, two different techniques. They're probably not doing one of them correctly. So it's also a good excuse for checking that we're on the right inhaler for them. And in terms of what is SABA overuse, so patients with well-controlled asthma shouldn't need a reliever more than twice a week. So if they're having it more than twice a week, they're uncontrolled. So if you only use that salbutamol 2 puffs, no more than twice a week, you only need 2 inhalers a year. So a collection of 3 or more is considered overuse, and we've got a very high rate of overuse within Nottinghamshire. I think my highest is about 150 salbutamol inhalers in a year for one patient. I regularly see 30 to 60 inhalers for patients that have been referred in. So we have a really big issue with overuse of salbutamol, and that is why this the concern about it. And the concern is because it is really clearly linked with mortality. Clear marker of patients with increased risk of exacerbations and mortality. The SABA study, which was in 2022, is a real-world study of SABA use in over 1 million asthmatic patients across 24 countries in 5 continents. So a lot of information there. And they found that 40% of asthma patients across all different severities, so low, medium, high, were overusing their SABA inhalers. So it's a huge proportion of patients. And then this consistently showed they were at increased risk of severe asthma exacerbations. So if they were only using sort of 3, I think 3 inhalers a year, so sort of 32% risk, increased risk of severe asthma exacerbations, and that risk rose with how many more numbers of SABA prescriptions there was. So it's a really clear risk with SABA overuse and mortality. So that is why we want to move away from it, and we know that the evidence now shows that the ICS LABA can replace it. So as I keep mentioning, they are coming in soon. We've got another meeting tomorrow with the guideline committee, and hopefully we are going to finalise majority of it, particularly some of the licenses, triple therapy and referral advice. I think we're hoping for April publication. It could be a bit later depending on the finalisation of things, but as soon as it is, it will obviously be sent out, and there'll be further teaching and promotion of it when published as well. And if there's anything in particular that you think needs to be covered, please shout up as well now, because it's really useful, because I can take that to the guideline committee tomorrow as well. I just thought, yeah, I've got some top tips and I can take some more questions. So main thing is ideally no new patient is newly diagnosed with asthma to be started on SABA. Hopefully you understand the reasoning behind MART and the licensing now. The main need for early reviews and referrals and checking adherence and inhaler technique at every review. And if you don't know how to do inhaler technique, you know where to go now with Asthma Lung UK or Right Breathe. A bit more aware of where pheno and eosinophils may be fitting in. The difference in the diagnosis pathway. And I think the overall thing is just making sure it's the right inhaler choice for each patient. As I said, these are guidelines, they're not going to fit every single patient, but hopefully gives you much more better information to give to the patient and get them on the right treatment going forward. Any more questions?
So we've got some good questions
Oh,
in.
perfect.
So Claire has asked, do you know where we can find a picture or the picture that you showed of the remodeling so that they can discuss that with patients?
I think I just found it oh, it's just online. But I'm happy for you to copy it off these slides when they get sent round. That's fine. It's not a I can't remember where it's from. I'd have to have a look.
Brilliant. And then Rachel's asked, in terms of air, what would be the PRN max dose before moving to low dose MART?
So
when would you step up, in other
when would you
words?
step up? Okay, yeah, because it basically if they were having symptoms sort of twice or more a month. So if they were having, you know, coming to have an exacerbation, then we would step them up. But if they were having repeated symptoms more than twice a month, then you would step them up. So it's quite a very small population of patients realistically. And the reason for that is because if they've got asthma and they're having symptoms, we've just shown you about the tissue remodeling. Those patients that are on air are not getting that continuous steroid, so they're not going to be dampening down that inflammation. So those patients that are having more symptoms, they're at more risk of having that tissue remodeling. So we want to get them on a regular inhaler instead.
Rich said, how many times a day can they use it?
In terms of air?
Yeah, in terms of air.
So each one licenses is slightly differently. But I think sort of for your sort of Symbicort, I think it's up to sort of 8 times a day. But each one is slightly different. We'll put them on the new guideline, the licenses of them, and then I think it'll be the same for Foster. It'll be 8 puffs a day as well. And I think your Durarest will be similar as well. But we'll make sure it's clear that we've just produced like a table of the licensed of the licenses and guide then the doses for them, so it should be nice and easy to just step up from one inhaler from air to MART to low dose MART to moderate dose MART in terms of the dosing.
I have to admit, I have to check every time with the different inhalers.
It's a minefield, and that's some of the discussions we're having is, yes, some of these inhalers are licensed, but I don't want to introduce loads of new ones to you guys when you're just kind of getting used to certain inhalers. It's already a new system, a new guideline. We need to try and make it as easy as possible for everyone to follow. So we'll try and keep it as simple as we can.
And then Elizabeth put, for suspected exercise-induced asthma, would we start with air?
Yes, so if they're again, it depends on their symptoms. So if their symptoms are, you know, if it's less than twice a month, they're actually getting sort of an exacerbation or symptomatic with it, then yes, you could start with air. If it's more often, then you might want to consider low dose MART.
Ken asked if you could show the referral guidelines slide again. I don't think you mentioned occupational asthma. Is that something we should be looking for as well?
Yes, yeah, it would be. Sorry, it's only so much to. Oh. I can't hear that properly. Was that someone asking a question?
They've just arrived and didn't
that's fine. No, muted them. So is that the referral one that they wanted? As I say, we'll have a bit more detail. This is just kind of giving you a rough idea for now. In terms of occupational asthma, yes, it is. There's just only so much I could necessarily fit in. Obviously, the main for occupation, we're trying to avoid the triggers, but that's obviously not so easy. But you would still treat it in terms of symptomatic. So if they were symptomatic more than twice a month, you might want to start them on low dose MART and then moderate dose MART. They are probably given more of an allergic phenotype, so you might want to be going for montelukast first rather than LAMA. So it might impact there as well.
Brilliant. It says, how come Symbicort for air is 200 and not 100? Is it because they aren't getting the continuous steroids?
Yeah, and it's just the one they're licensing they've gone for. I think it would be because they're only getting a very short burst of it. And that is the, when you think about Symbicort 106, although you have to remember that Foster is extra fine particles. So though it says, phospholiphebec is 106, in terms of the equivalence to Symbicort, it is equivalent to 206. So I wouldn't get too het up on the numbers. It's just in terms of actual equivalency. Beclomethasone in Foster is a bit extra fine, so you're getting more. It's more potent than your Symbicort. So Symbicort 106 is a really, really low dose. So it all comes down to potency, and each steroid is not exactly equivalent.
So thank you so much, Natasha, for coming today and helping clarify a lot of the muddy issues in my mind about asthma. Hopefully it's helped some of you guys. Some people wish they'd had a longer session because there was so much going on.
I'm more than happy once the guidelines are obviously out. I think, as I said, there's a few bits that are still not quite clear that I can say, yes, this is definitely the way we're going to go down. More than happy to explain our actual guidelines when they come out if there are any questions, and if there's anyone that has questions after this, and feel free, I don't mind if they want to email me, that's fine.
Thank you, and thank you all for coming in for such great questions.
Great, it's a great turnout as well.